In this video, we are going to discuss your mitral stenosis. Mitral stenosis is the narrowing of mitral valve orifice causing obstruction to the blood flow from the left atrium to the left ventricle during diastole. So there is decrease in mitral valve surface area that leads to increase in LA pressure and pulmonary congestion. So what happens here? Now look, this is the healthy mitral valve. This is opening completely. But in case of stenosis, the valve is not opening completely. So it causes obstruction to the blood flow from left atrium to the left ventricle. That leads to volume overload inside the left atrium. That leads to increase in left atrial pressure. It is transmitted into the pulmonary vein because the left atrium is connected to the pulmonary veins. So there will be rise in pulmonary capillary venous pressure, and there will be rise in pulmonary capillary OH pressure, and that will lead to pulmonary congestion and dyspnea, or pulmonary edema can be there also. So let us discuss some anatomy. So largest valve is tricuspid valve. Mitral valve surface area is 4 to 6 cm square. Aortic valve surface area is 3 to 4 cm square. The chordae tendineae attached to the two group of papillary muscle. They are anterolateral papillary muscle and posterior middle papillary muscle. Affixed to the left ventricular valve. The posterior middle papillary muscle has single blood supply. This anterolateral papillary muscle is supplied by both left coronary and right coronary, but the posterior middle papillary muscle is only supplied by right coronary. So in case of inferior valve MI, where RCA is involved, the posterior middle papillary muscle blood supply is lost. That leads to mitral regurgitation. So what are the causes of MS? Rheumatic heart disease. Rheumatic heart disease is the most common cause of MS. Congenital parachute valve, SLE, RA, myxoma, infective endocarditis with large vegetation. So pathophysiology developing MS, acute rheumatic fever, valvulitis associated with the MR. First most common lesion in valvular lesion in case of acute rheumatic fever is MR. Then MR develops into MS. So valvulitis associated with the MR, rheumatic heart disease, MS plus MR is the most common presentation. MS plus AR, AS plus AR. So thickening of valve leaflet, inflammation and fibrosis of the valve, fish mouth appearance of the mitral valve seen in case of rheumatic heart disease. Then there will be calcification. It immobilizes the valve leaflet. That leads to stenosis, or it causes the obstruction in the blood flow from left atrium to the left ventricle. It predisposes to thrombosis because due to obstruction to the blood from LA to LV, blood is accumulating inside the left atrium. So it is due to stasis of blood, and there is a risk of thrombosis there. So American Heart Association classification, severity based on the mitral valve surface area. Progressive MS, mitral valve surface area more than 1.5 cm square. Severe MS can be symptomatic or asymptomatic. Mitral valve surface area is less than 1.5, or very severe MS, mitral valve surface area less than 1 cm square. So mild to moderate MS presents with dyspnea on exertion. So how it is asymptomatic at rest. The patient is asymptomatic at rest, but when stress, exercise, pregnancy, fever, atrial fibrillation, in all these conditions there will be tachycardia. So what happens in tachycardia? What is the duration of normal cardiac cycle? It is 0.8 second. How it is calculated? It is 60 by 72 beats per minute. So if there will be tachycardia, if the 72 will increase, then the 0.8 will decrease. From this 0.8, 0.1 is atrial systole, 0.7 is atrial diastole. So if it is decreased, mostly diastole will be decreased. So in case of tachycardia, there will be shortened diastole. So there will be shortened diastole in tachycardia. If there is shortened diastole, already there is obstruction to the blood flow from LA to LV. Now the diastole time is also reduced. That leads to increase in blood inside the left ventricle, left atrium. There will be decrease in filling time due to shortened diastole or tachycardia. So more blood accumulate inside the left atrium. That leads to increase in left atrial pressure. It is transmitted in the pulmonary veins. There will be rise in pulmonary capillary venous or OH pressure. That will lead to dyspnea or pulmonary edema. So this present with dyspnea and exertion. So dyspnea and exertion is the first symptom in case of mild to moderate MS. How we can treat it? We can treat it by giving beta blocker. Beta blocker decreases the heart rate. Beta blocker decreases the heart rate. That will lead to improvement on these symptoms. So when the heart rate is decreased, there will be normal duration of diastole. So there will be full filling time. Blood will move gradually from the LA to LV, even if there is an obstruction, because we have giving maximum time for filling of the left ventricle. And now there will be less blood inside the LA. That will lead to less increase in left atrial pressure, and it will relieve the symptoms. So no increase in LAP. In MS there is resistance to blood flow during diastole. So it is compensated by rise in left atrial pressure. Even left atrium undergoes hypertrophy. In case of severe MS, there is rise in left atrial pressure that leads to rise in pulmonary capillary venous pressure, pulmonary capillary wedge pressure, that leads to rise in pulmonary artery pressure, and it leads to pulmonary hypertension in long run. So pulmonary hypertension, it is due to back pressure and reflex pulmonary vasoconstriction. So pulmonary hypertension develop in long-term MS. So what are the manifestation of pulmonary hypertension? So pulmonary hypertension leads to, when there is pulmonary hypertension, there will be increased pressure inside the pulmonary arteries. The right ventricle is connected to the pulmonary arteries. Now the right ventricle has to pump with more force because there is increased afterload in the pulmonary artery. So right ventricle will undergo hypertrophy in the long run. So there will be right ventricular hypertrophy as pulmonary pressure rise. RV has to pump against high pressure resistance. So there will be RV dilatation and hypertrophy. When is RV undergoing dilatation, there will be tricuspid annular dilatation also. The tricuspid annulus will also undergo dilatation when this RV is undergoing dilatation. So that lead to functional tricuspid regurgitation. When the RV is undergoing dilatation, that annulus is also undergoing dilatation, that will lead to functional tricuspid regurgitation. So another finding in case of pulmonary hypertension, loud and palpable P2. Loud and palpable P2 in seen in case of pulmonary hypertension, pulmonary valve closes forcefully because the pressure inside the pulmonary artery is more. The pulmonary valve will close forcefully because the pulmonary artery pressure is very high. Another is parasternal heave. Parasternal heave is due to hypertrophied right ventricle pushes against the chest wall. Now this right ventricle which has undergone hypertrophy, it will press against the chest wall, that will lead to parasternal heave. So right ventricular hypertrophy, loud palpable P2, parasternal heave, late parasternal heave. It will seen in case of pulmonary hypertension. Another is prominent A and V wave on JVP. So in JVP there will be prominent of A and V wave. A wave is due to if the right ventricle is undergoing hypertrophy, the right ventricle pressure is increasing. Now the right atrium has to pump with more pressure to compensate that. So right atrial contraction will rise, that will lead to prominent A wave. V wave is due to isovolumetric contraction. V wave is seen in case of tricuspid regurgitation. There is functional tricuspid regurgitation. So V wave is also prominent in case of pulmonary hypertension leading to all these conditions. So A wave is absent in case of atrial fibrillation, because in case of atrial fibrillation, atrial is not contracting, it is fibrillating. A wave is due to atrial contraction. In case of fibrillation, it is not contracting, it is fibrillating. So A wave is absent in case of atrial fibrillation. Large A wave is seen in case of tricuspid stenosis because right atrium has to contract with more force in order to overcome the stenosis. So large A wave is seen in case of tricuspid stenosis. Canon A wave. Canon A wave is seen in case of AV block or AV dissociation. Canon wave is seen in case of AV block or AV dissociation. And junctional rhythm, paroxysmal ventricular tachycardia. And large C wave is seen in case of tricuspid regurgitation. Large C wave is seen in case of tricuspid regurgitation. Absent X descent seen in case of tricuspid regurgitation. Deep X descent seen in case of cardiac tamponade, restrictive cardiomyopathy, and constrictive pericarditis. So deep X descent in these three conditions, that they are constrictive pericarditis, restrictive cardiomyopathy, and constrictive pericarditis, chronic constrictive pericarditis. So large A wave RA contract against high RV pressure, that leads to large A wave. Large V wave, TR causes blood flow back into RA during systole due to development of functional tricuspid regurgitation, that causes blood flow back into the RA during systole, that leads to large A V wave. So these are the JVP findings in case of pulmonary hypertension or mitral stenosis in the long run. So very severe MS. In case of very severe MS, very little blood enters to the left ventricle. There will be decrease in LV filling. There will be decrease in preload. When the preload is decreased, the stroke volume is also decreased. The cardiac output will decrease. In case of very severe MS, there will be decrease in cardiac output because the LV filling is decreased, preload is decreased. That lead to decrease in stroke volume. So cardiac output is decreased in case of very severe MS. So patient develop fatigue, weakness, cold and calming extremities in case of very severe MS. So we have a theory that is called theory of second stenosis. To protect the lung from excessive capillary pressure and pulmonary edema, the pulmonary arterioles undergoes vasoconstriction, medial hypertrophy, intimal fibrosis. So we see in case of mitral stenosis there is increase in LAP that transmitted into the lungs by the pulmonary veins, and there will be rise in pulmonary capillary venous pressure that leads to rise in pulmonary capillary OS pressure, increased blood flow to the lungs, so it predisposes to pulmonary edema. To protect the lung from these conditions, the lung undergoes some changes itself. They are vasoconstriction, medial hypertrophy, and intimal fibrosis. So these changes leads to high resistance. It creates high resistance, and pulmonary arteries and pulmonary capillaries undergo all these changes so that it can prevent the blood backflow of blood from the left atrium into the lungs. So beside MS there will be second stenosis of the pulmonary vascular bed. So stenosis, one stenosis is happening in case of mitral stenosis, we know that, but due to this MS there is a protective mechanism inside the lung. These pulmonary artery and arterioles, they are undergoing constriction and fibrosis and medial hypertrophy to decrease the blood flow in towards the lungs. This is called second stenosis. So it reduces transmission of high pressure to the pulmonary capillaries. So therefore pulmonary edema and hemoptysis may decrease. So pulmonary edema and hemoptysis may decrease due to this second stenosis phenomenon. The patient may improve symptomatically due to second stenosis, but the disease is more progressing. The disease is progressing bad, but the patient may see some improvement in symptoms. So this is what happens in case of theory of second stenosis. This is a protective pulmonary vasoconstriction and acts like a second obstruction of stenosis in the pulmonary vascular bed. So patient feels better temporarily as no dyspnea, but disease is worsening. Okay. So first stenosis was valvular, the mechanical narrowing of the mitral valve orifice caused by commissural fusion or rheumatic changes or calcification or whatever. So that was causing blocking blood flow from the left atrium to left ventricle. That was leading to increase or volume overload inside the left atrium. The volume overload in the left atrium leading to increase in left atrial pressure. Left atrial pressure is transmitted towards the pulmonary capillaries. Now the second stenosis develop in the pulmonary vascular bed. The reactive vasoconstriction, fibrosis, thickening of the pulmonary arterioles. This occurs as a protective or pathological response triggered by chronic high pressure in the left atrium transmitted to the pulmonary veins. So this is what is theory of second stenosis. What is A2AS interval? So A2 is closure of aortic valve. OS is opening snap. Opening snap is due to opening of mitral valve. So in this phase we are seeing isovolumetry relaxation. So during this phase the mitral valve opening, the closing of aortic valve, and the opening of mitral valve. This is called the A2OS interval. This is called the A2OS interval. So A2OS interval is inversely proportional to the degree or severity of stenosis. If the A2OS interval is less, then you can say the stenosis is more severe, because if this interval is less means there is already more blood inside the left atrium, so it is trying to get inside the left ventricle as soon as the valve is opening, or it will push the valve to open early so that it can transfer the blood which is accumulating due to a severe obstruction inside the left atrium to the left ventricle. So LAP, due to increase in LAP, more LAP, more early the valve will open. So due to, if there is more LAP, then it will open the valves early. It will open the valve early. As soon as the A2, there is closure of aortic valve, the opening snap will be there, or the mitral valve will open, because it is loaded. It is loaded. The back pressure is more. The left atrial pressure is more. In case of severe MS, the LAP will be more. So it will try to open the valve as soon as possible. As soon as the A2 is closed, it will try to open the mitral valve. So A2S interval is shortened in case of severe mitral stenosis. So A2S interval decreases due to increase in LAP in MS, shortening of A2H interval proportional to inversely proportional to the shortening of A2H interval proportional to severity of MS, and A2H interval is inversely proportional to the severity of MS. So the short is the A2H interval, the more is the severe the MS. So increase in heart rate, more early opening snap. In if a MS patient is on beta blocker, then there will be bradycardia. If the MS patient is taking beta blocker, then there will be bradycardia. Then A2H interval will decrease because the time will the heart is undergoing bradycardia, so the diastole is prolonged. So A2H interval is increased if a patient is on beta blocker. Okay, if the patient is on beta blocker, then the A2H interval is increased. So this is where the murmurs in case of MS. So this is the pre-systolic accentuation. Before the systole there is accentuation. Now there is systole. This is the A2OH interval between A2 and OH. As soon as the aortic valve closes, if there is increased LAP, the opening snap will be there. Opening snap means the mitral valve is opening because it is loaded with more pressure or raised LAP. So there will be mid diastolic rough rumbling murmur. This is the mid diastolic murmur, and followed by pre-systolic accentuation. We will discuss about the murmur later on. So this is what is the S1. This is the ejection click. Ejection click is the seminal valve high pressure opening. Ejection click is due to seminal valve high pressure opening. Opening snap is due to opening of mitral and tricuspid valve. Ejection click is due to opening of aortic and pulmonary valves. It is in case of systole, and opening snap is due to opening of mitral and tricuspid valve. So loud S1, it is in case of MS, TS and tachycardia. In MS, TS and tachycardia, we will hear loud S1. All other valvular heart disease produce soft S1. So except MS, TS, all other valvular heart disease produce soft S1. So this is what you have to remember. So S1 ejection click. Ejection click is heard in case of due to opening of aortic and pulmonary valve. If there is stenosis, aortic or pulmonary valve, aortic stenosis or pulmonary stenosis, then we will appreciate the ejection click during systole. Non-ejection click is also heard in systole. It is due to mitral valve prolapse. So non-ejection click is due to mitral valve prolapse. It is also heard in systole. So non-ejection click is due to mitral valve prolapse. Opening snap is due to opening of mitral and tricuspid valve. So features of pulmonary hypertension. So features of pulmonary hypertension is loud and palpable P2. I have discussed that. Due to rise in pulmonary artery pressure, there will be loud and palpable P2. Prominent parasternal heave due to right ventricular hypertrophy. Tricuspid regurgitation. I told you there will be dilatation of the right ventricle that will lead to annular dilatation, and it will develop functional tricuspid regurgitation. So due to functional tricuspid regurgitation, it will develop a murmur. So what is the murmur in case of tricuspid regurgitation? Same as seen in case of mitral regurgitation, the pansystolic murmur. So pansystolic murmur seen in case of tricuspid and mitral regurgitation. So pulmonary hypertension, RV dilatation, tricuspid annular stretches that leads to functional tear. So this tear murmur increases with inspiration due to increased venous return to right side of heart. So during inspiration, there is increased venous return to right side of heart because those SVC, superior vena cava, is extrathoracic, extrapericardial. All other structures, including pulmonary valves, pulmonary vein, and other four chambers of heart, they are intrathoracic. So during inspiration, there decreased pressure inside the heart chamber or right atrium, but there will be no change of pressure inside the superior vena cava. So there is a pressure gradient created after inspiration between superior vena cava and right atrium. So that will lead to more blood flow during inspiration towards the right side of heart. So if there is more blood flow towards the right side of heart during inspiration, so the right side murmur intensity will increase during inspiration. So tricuspid regurgitation is a right side murmur. So due to this annular dilatation and RVH, the tricuspid regurgitation develop in case of mitral stenosis. So if it is developed, it has developed, then during inspiration, the murmur intensity will increase with inspiration. This is called Caravello sign. It is called Caravello sign. TR murmur intensity increases with inspiration. This is called Caravello sign. Another thing in case of pulmonary hypertension can be seen in case RV failure. So RV failure, that will lead to congestion. Congestion RV, if the RV is failing, RV is not able to pump blood, then it will backflow into RA, it will backflow into superior vena cava, that will lead to rise in JVP, and it will backflow into inferior vena cava, that will lead to congestion inside the liver, that will lead to congestive hepatomegaly, edema and ascites. So these are the features of pulmonary hypertension. First is loud palpable P2, prominent parasternal help due to RVH, TR murmur, increases with inspiration, Caravello sign, RV failure, that will lead to hepatomegaly or congestive hepatomegaly, edema, ascites. What is hepatojugular reflex? Hepatojugular reflex is positive in case of impending right heart failure. So impending right heart failure, hepatojugular reflex will be positive. So if you press on the liver or around on the umbilicus, the blood from that area is pushed towards the right side of heart through the inferior vena cava, and if the RV is already failing, it can't accommodate the extra blood which is returning after the compression on the abdominal area. So JVP will rise, it will get centered towards the superior vena cava. So JVP will rise by 1 to 3 centimeter. It is normal. This is what is normal. It's called hepatojugular reflex. So this hepatojugular reflex, impending right heart failure, we see this hepatojugular reflex positive. What is the normal response? If you press on the liver, blood pushes towards the heart, normal RV accommodates, normal right ventricle accommodates the extra blood coming there. So RV accommodates, JVP rises by 1 to 3 centimeter only, and then it becomes normal as we remove the hand. But in case of abdominal jugular reflex positive, to diagnose impending right heart failure, apply pressure on the periumbilical region for at least 10 seconds. So positive hepatojugular reflex means JVP rises more than 3 centimeter. If the JVP rises more than 3 centimeter and remains elevated as long as the pressure is maintained, it is called positive hepatojugular reflex. So a failing right ventricle cannot accommodate the extra blood. The failing right ventricle can't accommodate the extra blood. So blood backs up into the systemic veins. So prominent pulsation on epigastrium, on suprasternal notch, and left second ICS. This is to parasternal hip, and all these things will be seen in case of pulmonary hypertension, right ventricular hypertrophy, or RV failure. So normally JVP rises transiently to less than 1 centimeter or 1 to 3 centimeter, can say, while abdominal pressure is continued. If the JVP remains elevated more than 3 centimeter for at least 15 seconds, it is a positive response or positive hepatojugular abdominal jugular reflex. Abdominal compression pushes the venous blood through the IVC towards the right side of heart. A failing or dilated right ventricle is not able to handle extra blood or extra venous return, so blood backs up into systemic veins, that will lead to a rise in jugular venous pulse, JVP. So positive abdominal jugular reflex in case of impending right heart failure, tricuspid regurgitation, COPD. In TR there will be volume overload inside the right ventricle, so extra blood cannot be accumulated by the right ventricle, so it will shunted into peripheral circulation, that will lead to rise in JVP. So positive abdominal jugular reflex in case of impending right heart failure, tricuspid regurgitation, and COPD. So false positive abdominal jugular reflex in case of Budd-Chiari syndrome. So false positive abdominal jugular reflex in case of Budd-Chiari syndrome, when hepatic veins are obstructed. In Budd-Chiari syndrome there is thrombosis in the hepatic vein, PNH, in paroxysmal nocturnal hemoglobinuria, the patient can develop Budd-Chiari syndrome. Remember that. So Budd-Chiari syndrome, hepatic veins are obstructed, hence the blood can't be effectively transmitted to the heart from the liver during compression. When we are compressing the abdomen, the pressure or the blood cannot be transmitted effectively towards the heart because there is thrombosis or obstruction of the hepatic veins. So there will be false, even if the LV is failing, there will be false negative abdominal jugular reflex. So major massive ascites, another cause of false negative abdominal jugular reflex, because pressure applied is not effectively transmitted to the abdominal veins. In case of massive ascites, the pressure will apply, it is not effectively transmitted in the abdominal veins, so it is not carried it away towards the heart, or we cannot see the positive abdominal jugular reflex. So these are the two conditions where you see false negative abdominal jugular. One is Budd-Chiari syndrome, one is massive ascites. So JVP we see giant A wave. Giant wave is seen in case of right atrial contraction or tricuspid stenosis. So in case of RVH, makes the RV steep, right ventricle steep, so RA has to contract against a less compliant right ventricle, so it has to contract with more force. That will lead to giant A wave, giant V wave. RVH, functional tricuspid regurgitation due to annular dilatation. So during systole or the isovolumetric contraction, the blood regurgitates back into right ventricle, from the right ventricle to the right atrium. That leads to large V wave. So all right side murmur increase with inspiration except pulmonary ejection click. So this you have to remember. The when we are taking inspiration in case of TR, the murmur intensity increase in Caravallo sign. All we have the rule, general rule, that all right side murmur increase during inspiration and all left side murmur increase during expiration. But there is an exception, that is pulmonary ejection click. Pulmonary ejection click is a right side murmur. It's in the pulmonary stenosis, but its intensity does not increase with inspiration. So pulmonary ejection click intensity murmur intensity does not increase with inspiration. So what is Kussmaul sign? Kussmaul sign is JVP raises during inspiration instead of falling normally. So during inspiration there is increased blood flow towards the right side of heart. So blood is coming towards the right side of heart. So JVP have to fall normally. But if JVP doesn't fall during inspiration, it is or rise instead of falling. JVP rises during inspiration. It is called Kussmaul sign positive. So it suggests the right side of heart cannot accommodate the increased venous return during inspiration. It is seen in case of constrictive pericarditis, restrictive cardiomyopathy, right ventricular infraction, severe right side heart failure. Or cardiac tamponade, we have to remember one thing, that cardiac tamponade has elevated JVP, and but usually doesn't show Kussmaul sign. So cardiac tamponade doesn't show Kussmaul sign. Kussmaul sign is seen in case of constrictive pericarditis, restrictive cardiomyopathy, RV infract, severe right side failure. It is that JVP rises during inspiration instead of falling. So it shows prominent, the cardiac tamponade doesn't show positive Kussmaul sign. So cardiac tamponade has other findings in case of cardiac tamponade. They are prominent X descent, absent Y descent, pulsus paradox. Pulsus paradox I have discussed earlier, that pulsus paradox means that after inspiration there will be decrease in systolic blood pressure by more than 10 mm of Hg. That is called pulsus paradox. It is seen in all three cases: constrictive pericarditis, restrictive cardiomyopathy, and cardiac tamponade. But Kussmaul sign is not seen in case of cardiac tamponade, but it is seen in case of constrictive pericarditis and restrictive cardiomyopathy. So Kussmaul sign is increase in JVP on inspiration causes a restrictive cardiomyopathy, constrictive pericarditis, and tricuspid stenosis. So there is stenosis of tricuspid valve. During inspiration, blood is coming like this. If this valve is stenosed, then it can go there. So there will be, it is shunted into the peripheral circulation. There will be rise in JVP. So rise in JVP is in case of constrictive pericarditis because it does not relaxing. Restrictive cardiomyopathy same region, tricuspid stenosis same region. So Kussmaul sign only positive in case of constrictive pericarditis, restrictive cardiomyopathy, and tricuspid stenosis. Normal JVP falls during inspiration. Kussmaul sign is not seen in case of cardiac tamponade. This is the most important point. So what are the symptoms of mitral stenosis? Dyspnea and exertion is the first symptom on increase in heart rate that leads to shortened diastole. There will be more blood accumulating inside the left atrium that will be shunted into the lung. That will lead to dyspnea or paroxysmal nocturnal dyspnea. Mild MS is asymptomatic at rest but represent as dyspnea on exertion. So moderate MS, dyspnea on rest. Mild MS is dyspnea on exertion. Moderate MS is dyspnea on rest. And features of right heart failure, there are ascites, edema, all these things. Pulmonary congestion in case of severe MS, recurrent infection. When there is congestion in the lungs, that will lead to recurrent infection, bronchitis. So severe MS, there is decreased cardiac output because preload is decreasing. That will lead to fatigue, cold, calming extremities, and decreased urinary output. So cold extremities, decreased urinary output, fatigue, all these things will be seen in case of severe MS. So increase in LAP can lead to atrial fibrillation or thrombotic emboli due to stasis of blood inside the left atrium because there is obstruction to the blood flow from LA to LV. So left atrium is enlarged, there will be increase in left atrial pressure. And another thing in case of MS we'll see in that is called mitral phasis. Mitral phases is that pinkish purple patches on cheek due to decreased cardiac output. So due to decreased cardiac output in case of severe MS, we will see mitral phases where the face is pinkish purple on cheek. So LA enlargement, lateral enlargement, it compresses the esophagus. So esophagus is just behind the left atrium. So if the left atrium is enlarging, so it will compress the esophagus and it compresses also the recurrent laryngeal nerve. So the compression of recurrent laryngeal nerve lead to hoarseness of voice, and the compression of esophagus lead to dysphagia. So this triad of dysphagia, left atrial hypertrophy, and hoarseness of voice, this is called Ortner syndrome. This is called Ortner syndrome. So pulse, what are the findings in case of MS? Pulse is normal, but low volume pulse can be seen in case of severe MS where cardiac output is decreasing. BP is normal, but reduced systolic blood pressure can be seen in case of severe MS due to low cardiac output. JVP during the initial stages JVP can be normal, but when there is involvement of right side of heart, then their A and V waves can be prominent. We have discussed the reason earlier. Apex is slightly displaced laterally. It is called tapping apex. Heaving apex was in case of AS. Tapping apex is seen in case of MS. So heaving apex was seen in case of MS, and tapping apex is in case of heaving apex in case of AS, tapping apex in case of MS. So what happens to heart sound? S1 is loud in MS, soft S1 in case of calcific or immobile leaflet. So remember, all the valvular heart disease S1 will be soft except MS, or in case of MS the S1 can be soft if the valve is calcified or immobilized. S2 can be loud and palpable P2. If there is development of pulmonary hypertension, then the S2 can be loud and P2 can be palpable. So S3 and S4 occur across non-stenosis valve. So S3 and S4 are occur against non-stenosis valve only. So there are never seen in case of MS. So S3 seen in case of failing heart, in case of aortic regurgitation with 3 S3. If there is systolic failure in case of aortic stenosis, we can see S3 also. S4 is only seen in case of aortic stenosis. So S3 and S4, they are never seen in case of MS or MR. MR can be seen due to systolic failure, but they occur across a non-stenosis valve. They occur only across a non-stenosis valve. Okay, S3 and S4, remember this thing, occur only across a non-stenosis valve. If the valve is stenosed, then there will be no S3, no S4. What is the murmur? Murmur is diastolic murmur. S1 is loud. S2, P2 can be loud if there is development pulmonary hypertension. There is opening snap due to opening of mitral valve. Mid diastolic rough rumbling murmur with pre-systolic accentuation. So mid diastolic murmur with pre-systolic accentuation. Rough rumbling murmur, heart based in left lateral position with bell of the stethoscope. There is a mnemonic called BELL. That means with bell of the stethoscope and left lateral position on increased intensity on expression, because it is left sided murmur. So severity proportional to duration of murmur. Severity of MS murmur is proportional to duration of murmur. Diastolic murmurs becomes louder just before the S1. This murmur is like this and becomes louder just before the S1. This is called pre-systolic accentuation. So the murmur of MS becomes loud just before the S1. This is called pre-systolic accentuation. So this is the normal heart sound: S1, S2, S3. And in case of aortic stenosis, we see ejection systolic crescendo decrescendo murmur. In case of aortic regurgitation, we see early diastolic decrescendo murmur. In case of mitral stenosis, we see opening snap, mid diastolic murmur with pre-systolic accentuation, and loud S1. In case of PDA, we see continuous murmur. PDA is continuous murmur. And in case of MR, we see the pan-systolic murmur. So these are the type of murmurs in case of other valvular heart disease. So MS, it is low pitched, rough rumbling, mid diastolic murmur in left lateral position with the bell of the stethoscope at the end of expiration. And other type of mid-diastolic murmur are, one is Austin Flint murmur. Austin Flint murmur discussed in case of severe aortic regurgitation. The blood flow from the regurgitant blood flow strikes as a jet on the anterior leaflet of mitral valve and pushes it, and it causes a functional MS. That is a kind of mid-diastolic murmur. So mid-diastolic murmur, other than the MS murmur, is Austin Flint murmur, and it is Carey-Combs murmur. It is in case of acute rheumatic fevers. In case of acute rheumatic valvulitis, no loud S1, no thrill or no opening snap. This is Carey-Combs murmurs in case of acute rheumatic fever. So difference between mitral stenosis murmur and Austin Flint murmur. So both are mid-diastolic murmur. So mitral stenosis murmur is mid-diastolic murmur with pre-systolic accentuation. S1 is loud. So in case of mitral stenosis, it is mid-diastolic murmur with pre-systolic accentuation. But Austin Flint murmur, it is heard in aortic regurgitation, severe aortic regurgitation, and there is also, in case of AR, there is murmur, diastolic decrescendo murmur, that will be also heard in case of AR, along with Austin Flint murmur, that murmur will be also heard. But in case of MR, only MS, the mid-diastolic murmur will be heard. It is functional MS, it is actual MS or structural MS. So opening snap is present in case of MS murmur, no pre-systolic accentuation, S1 is not loud, and opening snap is absent. So in Austin Flint murmur, although it is a mid-diastolic murmur, S1 is not loud here, opening snap is absent, and there is no pre-systolic accentuation. So there will be also presence of peripheral sign of AR. There are the signs of wide pulse pressure. So they will be present in case of Austin Flint, along with Austin Flint murmur, if it is a case of AR. But these signs will be absent in case of MS. So pulmonary hypertension present in case of MS, because in the long run MS develop pulmonary hypertension. And it is tapping apex. Tapping apex is seen in case of MS. Heaving apex in case of AS. Hyperdynamic apex is seen in case of AR, and pulmonary hypertension is absent in case of AR. So these are the difference between MS murmur and Austin Flint murmur. Both are mid-diastolic murmur. MS murmur plus MS murmur has, along with mid-diastolic murmur, MS has pre-systolic accentuation, loud S1, opening snap, pulmonary hypertension, and tapping apex. In case of Austin Flint murmur, it is heard in case of functional MS or severe AR, no pre-systolic accentuation, no loud S1, no peripherals, no opening snap, pulmonary hypertension is absent, there is hyperdynamic apex due to atrial regurgitation, and there will be presence of signs of peripheral sign present in like aortic regurgitation. So associated murmur in case of mitral stenosis are pansystolic murmur of TR. In long run, due to annular dilatation, right ventricular hypertrophy, it is developing TR. So there will be presence of a pansystolic murmur also in the long run. It is best heard along the lower left sternal border. In case intensity of the inspiration, it is called Caravello sign. High pitch diastolic decrescendo blowing murmur can be heard along with left sternal border associated with pulmonary regurgitation. If there is pulmonary regurgitation, then there will be diastolic decrescendo blowing murmur can be heard. It is called Graham-Steele murmur. So it is Graham-Steele murmur, high pitch diastolic decrescendo blowing murmur may be heard along the left sternal border in case of associated pulmonary regurgitation. If MS is associated with pulmonary regurgitation, then there you can heard diastolic decrescendo murmur. It is called Graham-Steele murmur. So what are the ECG findings? So we see in case of mitral stenosis, so first ECG finding is due to hypertrophy of left atrium. It is P mitrae. P mitrae is due to left atrial enlargement, is the early finding. At left atrial enlargement means there will be notch. Notch will be broad notched P wave in lead 2. There will be normally lead 2. This is like this. P wave is like this. But in case of P mitrae or left atrial hypertrophy, there will be bifid P wave or notched P wave. You can see here there is notched P wave. And in case of lead V1, normally the P wave is like this, isoelectric. But in case of development of left atrial hypertrophy, it will be like this. So P mitrae due to left atrial enlargement, the broad notched P wave in lead 2, and in lead V1 the lower component is due to left atrium, upper component is due to right atrium. Due to LA hypertrophy, this lower component will be larger, so there will be deep in this. So it is in lead V1. So this is the finding in lead 2. This is the finding in lead V1 in case of left atrial hypertrophy or P mitre in case of MS. This is the early finding. Then when there is left atrial hypertrophy, in case in LAP, there will be development of pulmonary hypertension. When the pulmonary hypertension is developing, there will be development of right ventricular hypertrophy in the long run. If the right ventricular hypertrophy is developing, then ventricle becomes steep. Now the right atrium has to contract with more force, then right atrium will also undergo hypertrophy. So there will be development right atrial enlargement. It's a late finding right atrial enlargement. It is called P pulmonale. P pulmonale means due to pulmonary hypertension and right ventricular hypertrophy in the lead to the length it will increase by more than 2.5 centimeter. Here the breadth is increasing, here the length will increase, or the height of the P wave will increase. So this is the normal P wave in lead 2, but the intensity is increasing in case of right atrial enlargement. In lead V1, this is due to RA, this is due to LA. Now this RA component is rising due to right atrial hypertrophy in the long term sequelae of MS. So this is the what happening with RA in lead V1. In lead V1 normal it is like this. Normal it will the breadth is 2.5 small square and height is also 2.5 small square, so 2.5. Then now in case of RA hypertrophy, it is increasing, the height is increasing. In case of LA hypertrophy, the breadth is increasing with notched P wave. So these are the P wave voltage. The MS patient can develop also atrial fibrillation. What are the finding in atrial fibrillation? Atrial fibrillation, there will be absent P wave, narrow QRS tachycardia, irregular RR interval, irregular pulses in case of atrial fibrillation. So absent P wave, narrow QRS, irregular RR interval, fibrillating waves. So absent P waves are absent, fibrillatory waves are present. Now it is irregularly irregular RR interval. So this irregular appearance of QRS complex and absent of discrete P waves is the key to identifying atrial fibrillation. This wave-like forms we often see in close inspection to undulating baseline called fibrillatory waves. So these are the narrow QRS fibrillatory waves. The RR interval is irregularly irregular. The RR interval is irregularly irregular. Atrial fibrillation is slow, irregular ventricular rate. Another example of atrial fibrillation, absence and clear fibrillating baseline. Here the clear fibrillating baseline is absent. Only clues that the rhythm of the atrial fibrillation is irregularly irregular. You can see this is irregularly irregular. The RR interval is somewhere small, somewhere it is large. It is irregularly irregular RR interval along with absent P waves or presence of fibrillatory waves. This is the finding in case of atrial fibrillation. So there will be right ventricular hypertrophy. Right ventricular hypertrophy, first we have to see if there is right axis deviation. So how will know there is right axis deviation? Suppose this is the right axis deviation. So for this, lead 1 have to be negative QRS in lead 1, QRS complex in the lead 1 have to be negative. So QRS complex in lead 1 have to be negative, and AVF in lead AVF QRS complex has to be positive. So QRS complex is positive in lead AVF and QRS complex is negative in lead 1. That will lead to right axis deviation. So this is the right axis deviation. Right axis deviation 80 to 180 degree, 90 to 180 degree. So along with right axis deviation, tall R waves in V1 or R by S ratio in V1 is more than 1. So in V1, R by S ratio more than 1. Deep S waves in V5, V6, R by S ratio in V1. So R waves of more height seen in V1 or S deep is seen more in V5, V6. So it is V1. You can see, this is lead 1. You can see negative QRS in lead 1 and positive QRS in lead AVF. So this is right axis deviation. Right ventricular hypertrophy shifts the axis of QRS complex to the right, and this is right ventricular hypertrophy, the right axis deviation. Now you can see in lead V1, R by S ratio is more than 1. In lead V1, R by S ratio is more than 1. Large R waves are present, and in lead V5, V6, small R waves and deep S waves, big S waves and small R waves. So R by S in lead V1 is more than 1. big S wave in V5, V6 along with right axis deviation. This is the picture of right ventricular hypertrophy. So the most common cause of right ventricular hypertrophy are pulmonary disease or congenital heart disease. In which congenital heart disease there is right ventricular hypertrophy? It is etiology of Fallot. It is one of the four findings in etiology of Fallot, right ventricular hypertrophy. So what are the chest X-ray finding in case of MS? So backward displacement of esophagus by LA enlargement in lateral view X-ray, straightening of the left head border, there will be straightening of the left head border, and splaying of carina. Splaying of carina means the angle is obtuse. This is splaying of carina. Splaying of carina, the left main bronchus. So the left main bronchus is lifted up by enlarged left atrium. So due to this enlarged left atrium, this lifts up the left main bronchus. So the left main bronchus is lifted up by enlarged left atrium. This is called splaying of carina. So enlarged left atrium, it also produces double shadow. Enlarged LA projects behind RA. This is double shadow. You can see this is double shadow. Enlarged LA presents behind RA. So double shadow, splaying of carina, straightening of left heart border. These are the findings in case of X-ray in case of MS. So double right heart border, you can see here double right heart border, left atrium, right atrium, or double shadow, enlarged LA project behind RA, and there is splaying of carina due to enlargement, straightening of left main bronchus due to hypertrophy of left side of heart. Another is prominent left atrial appendages is in case of here. Here you can see mitral valve prosthetic mitral valve is present here, and this forms double right head border. Double right head border is in case of MS and cardiomegaly. An echocardiogram, transthoracic echo TTE, to stage the MS, presence of MS or calcification, we can know it via the transthoracic echo, by the transesophageal echo, to rule out LA clots. To rule out clots inside the left atrium, we do transesophageal echo. To rule out tumors resembling MS, which tumors resembles MS, that is left atrial myxoma. So there is a complex or syndrome called Carnes complex. It is associated with cardiac myxoma, skin pigmentation, endocrine tumors. Cardiac myxoma, skin pigmentation, endocrine tumors like pituitary adenoma, adrenal cortex, or Cushing syndrome, testis, or all these things. This is Carnes complex, skin pigmentation, left heart myxoma or myxoma, skin pigmentation, lentiginosis, left heart myxoma, and the endocrine abnormalities like primary pigmented nodular adenocortical disease. This is called Carnes complex. Myxoma is in as a part of Carnes complex, skin pigmentation, endocrine tumors. So what is the management? Indefinite warfarin into patient with atrial fibrillation or clot or INR 2 to 3. You have to give them warfarin so that this clot undergoes lysis. No role of NBAC in MX, prosthetic valve placement, PMVVC, percutaneous mitral balloon valvotomy, or commissurotomy. This is done here. Contraindication is calcific MS, thrombus formation, predominant regurgitation, decreased heart rate, beta blocker is life-saving drug. Mitral valve replacement. Contraindication to mitral valve replacement, calcific MS, thrombus formation, predominant regurgitation.